My name's Craig Strenger, and I'm the Vice President of Operations and Strategic Development for MGFA. And I have the distinct pleasure of introducing our next speaker, Tom Bartlett. And Tom is a person with MG and a very, very plugged-in volunteer. So I asked Tom if he'd come up and talk a little bit about the easiest subject matter for a volunteer, and that's fundraising. And I told him I was going to steal his line, and we did rip it a little bit, and I want Tom to be able to talk peer to peer, patient to patient, caregiver to patient about connecting with the organization through fundraising as well as other areas. Tom has also been identified as our registry ambassador. So there's a lot of ways to get involved with MGFA, and I'd like Tom to tell you how. Thank you.
So I was talking to Craig just after lunch and said, oh, that's what I'm going to open up with. He said, it's great. I'll steal it. Okay. What's that? I can't hear you. Oh, like here? That works? So I'll say it again. Craig stole my line. And, but the idea, there's an idea that fundraising is easy. And it's really not. And there's professional organizations that do fundraising out there. So as patients and caregivers, how do we help? And I have a theme, and I'll pause for a second on the theme, but I've been doing fundraising for a long time. I've been doing fundraising for the American Foundation for Suicide Prevention. I've done that quite a bit, the walks that they're out there. And I learned a lot, and it's not easy. But what I did learn is 1 is better than 0 and 2 is better than 1. And it's that multiplier effect. And as patients, it's really hard to go out and ask people, raise money. And then I use the guilt factor. You're helping me. And you're helping the community out here. And you're helping the organization affect outcomes in science. In my professional life, that's what I did. I worked for a life science consulting firm. And our job was to reduce time to outcomes. But you can only do that with money. And it can sound very evil at times, but that's what gets the train going. And you've heard in here, and I'm also part of the MG registry and research as a patient ambassador, how many times that the registry was discussed. But the registry does not get created without funding. So I'm not going to talk to you about the tips and tricks about how to raise money, but the importance of connecting with the people that you know and not rely upon yourself. And that's one of the hardest things. And I've done that with my family members. And I've heard, yeah, Tom, I really want to do that, but I can't ask people for money. It's really hard for me. And I'm like, okay, well, maybe you talk to somebody else who can ask for you. And that's where you use the idea of what I would call a multiplier effect. So you're looking to people that understand you, because we have this, I call it an insidious disease. We sit at these tables, we look at each other, and if we didn't know we had a disease, we go, oh, he looks okay, she looks okay, until they get up and walk or not walk. We have wheelchairs in here and other assisted devices that many of the folks just, they don't see. So this is what we're trying to do, is extend our ability about 2 is better than 1. And I looked at, I looked at all the fundraising in the past years. And I've done quite a bit for the MGFA. And I would see like Tom's Rockets, spectacular, but not everybody's Tom's Rockets. And we love Tom for what he did. But the idea that the top 5 or 6 fundraisers, they did well. But after that, it was significantly less. And it's not a bad thing. So what we're really trying to say is, if you raised $100 last year, Can you get it to 2? You know, how do you extend that? And I did a bit of math last night, and I was like, well, if we can get 15 donations out there, and this is high level stuff, and I did some numbers. If we get people to say, I'm going to look to commit to raising, say, $750, and you get 100 people, that's $75,000. Now you disperse that out. You get like an 80-20 rule there. And I'm going to say, all right, you raise your 100 if we get it to 2. That goes right back into what the MGFA, their vision is. And you look at their 4 pillars. And, you know, research is part of that. And that contribution to that community, and you've seen the people up on the stage and what they're doing. You know, I think about and I wrote it down as like the many choices today in 2024. When I got diagnosed, it was 2019. There was one outside of the traditional stuff. There was one, and I was grateful for that one, but it took me 2 years to get to it. Now we have, I've forgotten the numbers really between subcutaneous and IV, and there's some other great ways that are going to be coming out. And you see all the companies that are out there. That's where you see, oh, it's beyond choice. It's not like I'm going to choose Pepsi over a Coke, but each one can be the idea of being tuned the way we're reacting to the insidiousness of MG. That means it's not choice at this point. It's now I have an alternative that I didn't have before. And I've been around the fundraising, and fundraising can be kind of a dirty word at times. It's the idea that I got to go ask people for money, and I am not comfortable with doing that. It's the idea of how do we get past that idea of saying, if I can get to that 1, can I get to 2? And the amount of effect it has on you personally, as well as everybody else in this room, and then the people you don't know. And I look at that number. So that number, if we look at the numbers, and it's anywhere, you know, 40 to 70,000 people in the United States. And if you think about, oh, what are the ones that haven't been diagnosed yet? Maybe it's 100,000. Let's get them in part of this, and let's see if they're a clinical trial that's going to affect them. So that's really what I wanted to talk about here is in terms of fundraising. It's not giving you these tips and tricks because there are others out there, and we heard some of the award winners last night, how well they've done. You know, you can share with people. There are other things like, you know, match programs where you work. One of the most successful ways I've raised money, like as a side thought, was using Facebook. I raised almost $1,000 last year, just saying I turned that on, and here's where you can donate money. Is zero effort for me, besides what I was doing on my own in my community that I was reaching out to. So this is the idea that everybody in this room is going to feel some impact of the work that we do to bring money in to the MGFA, and the idea of looking at the MG registry, which I think is one of the best things in the world that we have. And registries, by the way, if you're not familiar with it, they're used in all science. I was at a conference last week, the World Orphan Drug Congress, and registries for rare diseases is the #1 topic because they're desperate for information. So the idea of using the registry, and the only way we can get the registry is we have funds, and you can see where this goes. So the idea of me coming up here as a patient, it's selfish. It's selfish for us because the results of our activity in raising money, ultimately, in the big picture of things, will help me. And sometimes we have to think that way. So it's kind of what I wanted to talk about. Be open to answer any questions. Anybody has any? Yeah. So my Facebook page, have stolen a graphic about MG, and that's my background, my Facebook. And then I am posting constantly about MG studies, what the MGFA is doing, any research that's being done. And I do writing for the Rare Disease Advisor. So I post all of my articles there, anything I can that spreads awareness. So when I do go, hey, I need money, they know what I'm doing. Okay. Oh, is there another question? No. Oh, sorry, I didn't see it. Can you help her? Because I can't hear either. I'm a big believer in being bold. I'm not subtle. I will tell people I want your money. And we use a little bit of humor in that, but that's, we got, I can't hear anyway, so, yeah.
I was good yesterday. Do you put like a separate page?
I don't, because I want it to be connected to me.
Okay,
And that's my personal approach. That's why there's so many different ways, and you've heard some of them last night. I'll do the walk, and I haven't really started that push. And what I've found with walks and such, it's the last 2 weeks.
yeah. Well, the two groups that I manage, one of them is an international.
Yeah.
And the other one is more local or United States. But I'm just trying to I know we do partner with you and you do send us you're a member of ours and you do send us your information. But as I said, I'm trying to figure out, do we put it like a post? Is that what you do?
I'm sorry, I did not.
Yeah, see.
At times I do. So my
Okay.
signature box
Uh-huh.
on every email that I send out both personally and professionally, talks about I'm an MGFA ambassador,
Uh-huh.
and I am a personal ambassador in the MGFA community now. Like with the walk coming up, and then June especially, there'll be a link. And the link there will be, here's how you're going to give me money.
Okay.
And I'll probably phrase it that way.
Well, we have
Not
a
on my
walk.
professional side, my
It's-
personal side.
It's true. Well, we have a walk right now coming up. It's the MGFA in Boston.
Yep.
So I guess we can try that. 'Cause we never did that.
And be bold, It's-
Okay.
we don't need to be shy about all of that. I
Right,
do
thank
want
you.
your money. Go ahead.
Here, we have another question.
I know that they may not like what I say, but I usually break the rules as a. Yeah.
So I am just like you. I'm
Good.
very direct.
Yeah.
No, I just wanted to say like, I'm 100% with you. Huge supporter of the registry. I just think it's so important because there's so few of us essentially for the data to all be available in one place. Like it's super important to me. Even it gets back to the themes we were all talking about earlier and asking the doctors about just like we all need uniform testing. Like, sure, you're ACHR positive, but let's test that across the board. If you're seronegative, let's prove it. Let's get this question of the mitochondrial stuff, out of the way, or the genetic issues out of the way. So 100% with the registry for that reason. So just that comment. And then the other thing is like, what do you say to people? Like, do you have a way to say it to people when they say like, oh, well, I don't want them to have all of my information. Like, what would you say to
Like
respond to
registry?
someone?
Well,
Yeah.
There's folks out there that will be able to answer that question directly. Tomorrow, we're going to talk about that too. But the idea, everything is anonymized or it's de-identified is a better way to
Right.
to discuss it. And if you're talking to regular folk, they don't know what de-identified means. So all that information is no longer captured. It's captured, but it's not in the information that's being shared.
Right.
That you have to provide authentication that if you do want to share, and this is the way registries work in general, that if you want to share some personal information, that's a choice that you make. So that if somebody wants to do a clinical trial, they got to know who you are.
Right,
But
right.
in the collection of data, they don't know who you are.
Perfect. That's the answer I needed to know.
Yep.
How to respond. Thank you.
That's all right. I want your money. Give it to me now. And that will be your tagline on every email you send out. Right? So, and we've got a confirmation from the back of the room, so that's a must. So, no, that's it. Go get money, bring it in, because it's going to help us.
Good job.
Thank you.
Thank you, Tom. For anybody that does have any questions about fundraising or tips or emblems or social media fundraising, anything like that, go to the website, reach out to Tasha. You can see the email. You can talk to Tom privately here, or I'm sure he'll be happy to spend time with you via email or phone. So there's multitudes of people that are here to help and get you over the fear and make it easy for you. So Tom, thanks again. Appreciate it. And I'll turn it over to Laura.
Hi, my name is Laura Chandler. I have been living with myasthenia gravis since 2019, and now I serve as the National Director of Academic Affairs and Research Initiatives at the Myasthenia Gravis Foundation of America. I am so honored to get to introduce Dr. Ali Habib. Dr. Habib is a board-certified University of California Irvine health neurologist who specializes in neuromuscular disorders, including muscular dystrophy, ALS, neuropathies, and MG. He earned his medical degree at Aga Khan University in Karachi, Pakistan. He completed an internal medicine internship and residency at Cornell Medicine. He also completed a fellowship training in neuromuscular medicine and neurophysiology at Columbia University. Dr. Habib volunteers for the MGFA as a member of the Medical and Scientific Advisory Council. And volunteers is kind of an understatement, as we all learned last night when he was awarded Medical Partner of the Year for the Myasthenia Gravis Foundation. He is our favorite instigator, and I am so looking forward to hearing him speak. Come on up, Dr. Habib.
Hello, everyone. Can you hear me? I was told to project my voice, and I was like, wait, I don't know what that means. Anyways, there's only one thing that's worse than standing between an audience and lunch. It's getting them after lunch. Now the sleep begins to come in. So hopefully I can keep you stimulated. I'm sorry I wasn't there last night. I did not open the email that Dova sent me telling me I was getting the award, so I missed the only award I've ever gotten. So sorry for that. And many more come before me and who've been doing this for a lot longer than I have. So it really is an honor for me to receive that. I don't really do that much to deserve it, but I'm happy to have that. Let's see if I can figure things out here. Anybody have any questions about MGFA registry? Sorry, I'm not sure what's great questions about the MGFA registry. If there was any data about the utility of the please come to the session tomorrow morning and you'll hear a whole lot more about it. And with that, it's not working. The reason I asked for a mic is because I'm very restless. I move around a lot. And I was like, I'd be going in and out with that mic. So clearly I can't deal with that either. All right. So my talk is about seronegative myasthenia gravis. And we heard a bit about that this morning from Dr. Mopidi as well. And anybody know what that picture is about? No? That is the Indian chief, the earliest possible case of myasthenia in the 17th century. Chief Opichan Kanwa, I probably butchered that name. He was in Virginia in one of the tribes, and he had myasthenia, presumably because people would have to keep his eyes held open as he addressed his subjects. Here are my requisite disclosures. And I wear a lot of hats, and you guys heard about some of these last night. Some of these words are not of my own choosing. After hearing Dr. Mopidi, I'm gonna delete that because he is clearly a better presenter than I am. But the ones that I'm really excited and proud about are these ones. And again, you heard about that already. I like to create trouble, right? So that's part of what this talk's gonna be about, being provocative, being the pot stirrer here. And in case people do decide to fall asleep on me, here's my entire talk, okay? This is the summary. So seronegative myasthenia gravis can be confusing, and I had originally written, I will try to clear it out, but Dr. Mopidi already did my job for me, so that's why he's up there. The diagnosis of myasthenia gravis, we heard a lot about antibodies this morning, and it's a lot more than just being an antibody, okay? And we'll talk a little bit more about that. It's very important to know your condition, and it goes both ways. Having your diagnosis of MG being missed, but also being misdiagnosed as MG. And I'll spend some time on that. And it is, as Dr. Mopidi said, very important to know your antibody because a lot of the therapies that are currently available and approved, especially the newer medications, are very selectively being approved for these antibody types. And the question is why? Why is that happening? And I'll tell you guys a little bit more about that. But the final point here is there is a lot coming to us in good things in myasthenia, and therapies are being developed by a lot of people in this room, by really awesome partners who are very vested in making the lived experience of myasthenia a whole lot better than it is. All right, so I'm not going to spend too much time on the antibody. We heard about this. This is another cool picture of that Y protein that the antibody is, stolen from some website. This is what the structure of the neuromuscular junction looks like. So just to sort of take it back, what you see in the light blue, that's the nerve fiber, what we would call the motor neuron. So this originates in the spinal cord, and it sends its tentacle out to the muscle, attaches to the muscle. And in the muscle, what you see are the muscle, and we've all seen this, right? You take well-cooked beef and it pulls apart, those shreds, those are the fascicles of the muscle. Each one fiber is a longitudinal fiber, and some point on there, the nerve attaches. So each muscle fiber has some point of connectivity with the nerve, and that's the neuromuscular junction. And that's what this picture shows. And again, our point of interest here are those teal-colored channels, which is the acetylcholine receptors, and the purple circles, or mauve, I'm not good with colors, are the acetylcholine molecules. And this signaling is basically at the crux of all neuromuscular junction disorders. You heard a little bit about Lambert-Eaton myasthenic syndrome, about autoimmune myasthenia, and there's congenital myasthenic syndromes. And there are all of these relate to defects with this signaling. All right. So I was always told to include history in my talks. So here's a little bit of a history lecture. So the story of myasthenia, the antibody story, the autoimmune story of myasthenia is really very old. This goes back to the 1970s. And Stan Appel and his group in Houston were the first ones to come up with the idea or identify that this was an antibody-mediated disorder, identifying the antibodies. And very shortly thereafter, Vanda Lennon and John Lindstrom up in my area in San Diego described this even further. And for reference, Vanda Lennon has been really the main person behind the Mayo Clinic autoimmune lab. So she's developed a lot of the antibody testing that we rely on for our diagnostic workup. Okay. And even back then, they had identified that these antibodies, the acetylcholine receptor antibodies, were of the IgG1 and IgG3 subtypes. There's subtypes within subtypes. And these fix complement. And again, Dr. Mupidi talked a little bit about that this morning, about what does that mean? So this is just giving you the background of why we say, oh, this fixes complement and this doesn't. Okay, so that's where this whole term seronegative and seropositive came about, even way back then in the 1970s. So simply anybody who has acetylcholine receptor antibodies is seropositive. Those who don't are negative. And moving on, you fast forward about 25 years to 2001, and that's when Angela Vincent and her group in Oxford described this antibody, the muscle-specific kinase antibody. And this became the largest group within the so-called seronegative myasthenia group. Now here, the MuSK antibodies, again, way back then, were identified as primarily being of the IgG4 subtype. So again, 1 and 3, 4. So IgG4 does not fix complement, does not activate complement the way IgG1 and 3 do. Okay. And a couple of years later, this publication from her group again talked about, well, there is a clear separation in the identification of these antibodies. So the group on the left, again, the teal triangles that you see are the antibodies being detected in patients who were seronegative and had MuSK. And in the middle and on the right, you see that the healthy controls and people who had AChR antibodies did not really have these, the MuSK antibody. And so just tying into one of the questions that was asked earlier this morning, are we missing people who might have both? And the occurrence of that is extremely rare. And again, a large part of the differentiation between the two types of myasthenia are on clinical grounds as well. Okay, we'll talk a little bit about that. More importantly, what Dr. Vincent's group also described is that people who had the MuSK myasthenia, MuSK antibody myasthenia, fit a different profile. Their disease was a little more severe than the ones who had AChR antibody. And more importantly, as Dr. Mupidi said this morning, they tend to have a lot more of bulbar muscle involvement. What does that mean? That means muscles in and around the face. So facial muscles, tongue, the muscles of swallowing and chewing, those kind of things. So it's a very distinct phenotype as we've come to identify it now. Now, that's not to say that MuSK cannot have the other features that you see in acetylcholine receptor antibody positive myasthenia. There is an overlap between them, but there is a distinction clinically as well. And then you fast forward another 10 years and you get to the LRP4 antibody, which constitutes a very small fraction within the seronegative group. So now this is where things get confusing because we use the term seropositive in different ways. At times is the conventional term back from the 1970s where it's AChR antibody positive is seropositive, If you don't have AChR, you're seronegative. But then again, what about these other two antibodies? And so that becomes a little bit, I mean, we're still figuring out what the correct terminology here should be or could be. All right, so the diagnosis of myasthenia, it really is aided by the identification of the antibody. And as Dr. Mopidi said this morning, if you have the antibody, you don't really need to go doing all those other tests. But I want to put a caveat to that. What he's saying is when you have a patient whose history and examination fit myasthenia, and you have an acetylcholine receptor antibody or any of the antibodies, then it's fair to not need to go to the electrophysiologic testing. What do I mean by that? So as fledglings in medicine, or at least in neurology, we are taught that the history is the most important part. And you'll be surprised at how often we don't take good histories. We don't put a lot of emphasis and attention to the details. And the devil really is in the details. And just by doing a good history, you can pick up those outliers where, yes, you have fatigue, but tell me more about that fatigue. What exactly do you mean by fatigue? Yes, you have double vision. Is it truly double or is it just blurred vision? And does it go away when you cover an eye or you don't, right? So those kind of things, not taking it at face value, but really asking more from patients. And patients are telling us this. You guys are all telling us this. We just have to have the patience to listen to it and to pick out the important details in there. All right. So how do we go about making the diagnosis of myasthenia? And just want to spend a little bit of time here again. So first and foremost, like I said, the clinical picture is super important, right? The hallmark feature of myasthenia is fatigue. The hallmark features of myasthenia is fluctuations. There's very few diseases that fluctuate the way that myasthenia does. And I'm talking to a group of experts here. I don't need to explain this any further to you, right? But doing a deeper dive into it, that's super important here. And then you go on to do the exam. And the exam for myasthenia has very particular features. It's not uncommon for me to see people, for all of us, see people who are sent for, but this could be myasthenia because they have droopy eye. But they have droopy eyes both sides. And it's always both sides. And it's always the same amount both sides. And that's very unusual for myasthenia. Most often myasthenia will, for whatever reason, do one eye more than the other, right? It's not that they can't get both eyes affected, but again, parsing through that detail, that's the important part here. And then when your clinical picture fits, then you go on to do this testing, because sometimes if the clinical picture doesn't fit, then you're doing other testing along with the testing for myasthenia, right? That's how we're supposed to do it. Electrophysiology plays a big role in this, and Dr. Mopidi showed great concepts and tracings for what it is that we're looking for on that testing. And then sometimes we're also looking at response to therapy to tell us and guide us as to this. In fact, the edrophonium test, which is basically extinct now because nobody carries edrophonium anymore, but folks used to carry it in their doctor's bag, you know, back in those days when people had doctor bags. We don't carry doctor bags anymore. They would take this out and do it. But there were some technicalities associated with it. Nowadays, we carry around ice because everybody likes to do the ice pack test. Okay. So in my practice, whether it's myasthenia or anything else, what I'm looking for is not just one thing pointing in a direction, but rather multiple lines of evidence pointing in that direction. And that's what gives me confidence that I'm on the right track. And even then, sometimes you're left scratching your head, you're left with doubt in your mind saying, I got to keep an open mind here because I may not be on the right track, right? All right, so misdiagnosis and misdiagnosis of myasthenia. this is a very, very challenging issue because the missed diagnosis of myasthenia clearly represents a therapeutic opportunity and a therapeutic window, right? So in this day and age, we don't think too much about what used to be called myasthenic myopathy. Myopathy, what does that mean? Muscle weakness, right? But myasthenic myopathy was this concept that you get to a point where the structure is so damaged that you cannot recover function from it, no matter what kind of treatment you use. And this leads to what we call fixed weakness. The muscle is permanently weak and you can't get it to be any better, no matter how good your therapy. And you want to avoid getting into that situation. But there is a ticking time clock for that, because if you don't get treated on time, you're losing that opportunity. Okay. Fortunately, this is not the common scenario. The common scenario is not that the diagnosis of myasthenia gets missed. A large part of that has to do with the antibody testing. It is so readily available, it's so easy to do that as long as the physician has considered the diagnosis and sent that antibody off, in 2 weeks you have an answer. Less than 2 weeks, you have an answer in the majority of instances, right? It's the misdiagnosis of myasthenia that's more challenging. And again, the fewer lines of evidence that are pointing in that direction, the more challenging that becomes. So I'm just going to give you a couple of examples of cases that we've seen at our center. So sometimes making a different diagnosis is pretty easy. So here's a 61-year-old man who is referred for drooping of the eyelids in November 2021 to us. And he describes it again. When you ask him, well, what is it that you are feeling? He's describing it more as a heaviness of the eyes with more effort to keep them open. Okay, feels tension in his forehead. Symptoms do fluctuate, just like myasthenia. The neuro-ophthalmologist that they saw noted fatigable weakness, meaning if they kept their eyes up, their eyelids began drooping more and more. You've all experienced this. We do this in clinic all the time. Was given a trial of mestinon and noted some improvement in the symptoms. But there's no double vision or other areas affected. And that's not unusual. People can have just droopy eye without having double vision. That's okay. Okay. And then they were seen by a neurologist and they noted fatigable eyelid drooping again, double vision when they're doing the testing. But the rest of the exam is completely normal. And the neurologist, and this is from their notes, says there's no doubt that he has autoimmune myasthenia gravis. Okay, great. Well, they go on to do the testing, and the repetitive nerve stimulation testing is normal. Antibody testing from 2 different labs, the Utah lab and the Mayo Clinic lab are both negative. Went to do MuSK antibody testing, and that's negative. I just want to pause here for 1 second and talk about lab testing in myasthenia. So not all labs are created equal, and we encounter this issue a fair bit. There is sensitivity issue with some labs. And again, the test being negative when it should be positive, what we call a false negative, is less of an issue rather than the test being positive when it really isn't, which is a false positive. And that's what people hang their hat on and say, aha, you have myasthenia gravis, right? And that's the bigger challenge. So anyways, testing for this patient is negative in both ends. So the first time they come to the UCI clinic, we're like, it's not really drooping that they have. Their eyes are not really going down like the curtain sign. And their forehead is doing funny things, and you get all kinds of different other questions asked, and said, you know what, I'm going to send you to somebody better than me. I'm going to send you to one of our movement disorders colleagues. And we did that, and lo and behold, their diagnosis really is that of blepharospasm. It has nothing to do with myasthenia. And the way you actually treat it is Botox, and you don't really give Botox in myasthenics, right? That'll just make things so much worse. So a life saved, well, eyes saved, okay? Well, other times it's not so easy. So here's another patient we saw. She's almost 70 by the time we're seeing her. Started having problems with her swallowing in her 50s. This swallowing, as she describes it, has been progressive. So it doesn't fluctuate, but over the years, it has continued to get worse and worse and worse. Okay. The same thing applies to drooping of the eyes, and has also developed weakness in arms and legs, as well as breathing problems. All of these symptoms, droopy eye, swallowing problem, breathing problem, limb weakness, these are all part of myasthenia, no problem at all, right? But the problem here is that it's all progressive over the last several years. So she had gone through all the testing was negative, got treated with seronegative myasthenia, and what are the treatments she's been on, okay? So she got Mestinon, little bit of improvement, got prednisone, was on prednisone for years, and again, maybe some benefit from it. Got IVIG, no improvement. Got eculizumab, once it got approved, no improvement. Okay, so now she's being termed refractory myasthenia. Getting plasmapheresis, as you heard Dr. Mopidi say, it's a very involved process. When you're talking about a catheter, you're talking about a large bore catheter that has to go in a major vessel. This is not what you do a blood draw from. So it's very involved and very labor intensive and requires specific, not even all places that do dialysis can do plasmapheresis. So that tells you, right? And when she first came to UCI, she could not open her eyes. But once you hold it open, she has good eye movements, so it does not have a lot of paralysis of the eye movements, and has very diffuse muscle weakness. More importantly, from all the years of prednisone that she's been on, she has all the stigmata of prednisone use. Face is all blown up, has the buffalo hump, skin breaks when you touch it, all of those kind of things. Diabetes is out of control, right? And then again, all the folks who've been on prednisone know of all of these effects. We did the requisite electrophysiologic testing, that's normal. We didn't think this was myasthenia to begin with, and we did genetic testing for a particular condition, and that was positive. So that basically undid this diagnosis, which she had carried for many years, had been through so many different treatments for it. And now I got to peel off all of those things that she had been on, stop the plasma exchange, take off the prednisone, take off all the other medications she was on, and nothing changed when she came off of these medications, other than the fact that the steroid side effects got better, right? So again, the point here is that really making sure we have the right diagnosis is critically important, not just from the standpoint of not missing the diagnosis of myasthenia, but also from the standpoint of avoiding the toxicities that we have associated with all the medications that we use for myasthenia. Okay, so just to basically summarize all of this, Dr. Yubing at Cleveland Clinic and his group did this study that's published last year, where they looked at all of their patients who had been referred for the diagnosis of myasthenia. And there were about 500 plus patients that were there. And they looked at how many of them actually had myasthenia and how many didn't end up having the diagnosis. And there were about 15%, so 70 plus patients who did not have myasthenia or had an alternate explanation for their myasthenia. That's a lot. If you take 15, even if you round down, that's 1 out of 10 people that were referred to their clinic who were given the diagnosis of myasthenia but did not have the diagnosis of myasthenia. Okay. And these are all the reasons that they found for why that diagnosis was made incorrectly. The clinical presentation was overlooked. The testing was equivocal. The testing methodology used or technical issues were overlooked. And the antibody testing, even in some instances, was very, very low abnormal. Okay. So excuse me, just highlighting all of those things. And what they said is that overdiagnosis of myasthenia is not uncommon and occurs more frequently in the seronegative myasthenia groups, right? Challenge upon challenge. All right, so just to bring this home, just things to consider. Making the diagnosis of myasthenia can sometimes be challenging. And if you're not confident about the diagnosis, seek help. Advocate for yourself. Ask for second opinions, third opinions, fourth opinions. I practice in an area in Southern California where I have the luxury of having many excellent centers around me. And we have no problem saying to our patients, you know what, I'm not sure. Why don't I send you to somebody else who can look at you from a fresh set of eyes and say, am I on the right track or not? Or get you a better answer, right? And honestly, no physician should, or no clinician should have that pride get in the way of helping patients. That really, pride has no role in the practice of medicine. And again, it's okay to reconsider the diagnosis of myasthenia. I've done this to my mentor, and he's done this to me multiple times, where we kick each other and say, haha, you got it wrong. And why is it important? Because alternate diagnoses can mean you avoid the toxicity of the treatments. It may actually open up the door for other treatment options for you, right? And especially in the case of some genetic disorders that can look and present like myasthenia, that then has implications for other family members as well, right? So not only may you, is it possible that your diagnosis gets undone, but a family member's diagnosis may also get changed because of your correct diagnosis. All right, enough of the doom and gloom. Let's talk about treatment options. So this is again paraphrasing something that Dr. Mopidi said this morning, which is coming from Angela Vincent, that seronegative MG is potentially misleading. Although these patients may not have the antibody, there is no reason to think that their disease is not antibody driven. And as he said, just because you don't have antibody, it just means that we've not found all the antibodies that play a role in myasthenia. So there is a deficiency on the medical information side of things, how much we know about this disease. Okay. So up until 2016 or so, we had fairly standard treatments that we borrowed and spread the love across all the different groups within myasthenia, with perhaps the exception of MuSK antibody myasthenia. And these are the therapies that, again, you've all heard of and know of really well, okay? And you kind of had them in different boxes based on, you know, how quickly they acted, how long they took, how problematic they were, all of those things. But 2016 onwards, the landscape has dramatically changed because of all the therapies that have come on. So Dr. Mopidi talked about the complement inhibitors. So eculizumab was really the main trial that led this field of development in myasthenia. And it was a very unique study. It was actually the only trial that looked at so-called refractory myasthenia patients. So these are the patients who had prolonged disease. The average disease duration in that trial was 10 years of having had disease, and they had failed, by definition, multiple therapies. And the response was remarkable. These patients who we would have thought we don't have any other options got better, and the majority of them got better. They didn't get normal, but there was still an improvement over what they had. That's huge, okay? All right, so again, these are the list of the drugs that have been approved. The two big categories there are the complement inhibitors and the FcRn inhibitors, as again, Dr. Mopidi talked about this morning. And there's a whole bunch coming in the pipeline. So many, we're struggling because trial enrollment is a challenge, right? So we need help from all of you to get these trials going, because to get these trials approved means better treatment options, means more treatment options, means hopefully more affordable treatment options. And with that comes the question of equity and access. A lot of these therapies are not accessible to folks. So that really is what we need to work towards. All right. Last bit, it took me an hour to do this slide. I hope it works. All right. So you've got the years in the bottom over there. These are the years in which these trials have occurred. Here it goes. Yay, it works. All right. Thank you. Quite proud of myself. My high schooler probably would have figured it out in 5 minutes. But what you have here is all the trials that have taken place in myasthenia. Now, actually, I should rephrase that. Most of the trials that have taken place in myasthenia to date, starting in the late 1990s, okay? So azathioprine, way back when, and then 10 years go by before mycophenolate trials come on. And then once you hit 2016, somebody presses on the accelerator and the field starts booming. What's with the colors? Okay, so the blue dots are all the trials that only included acetylcholine receptor antibody positive patients. Most of these trials were generalized, so I'll just say that. Okay, the green dot, when you mix yellow and blue, it becomes green, right? So the green dots allowed for some seronegative, again, most of them because of how you get identified and whatnot, were MuSK myasthenia patients. So some of the trials, the first one being rozanolixizumab, that's a real tongue twister, included MuSK patients. But then as you move towards the right of that picture, you see some yellows creeping in, and that now is talking about exclusively enrolling seronegative patients, okay? So argenx has a trial exclusive to seronegative in using efgartigimod in their in myasthenia, and the MuSK trial for Cabaletta Bio, which is a CAR T therapy, new wave of new age technology, is also exclusively enrolling MuSK patients. And so there's been a change, and we've really been talking about the unmet need. That's a real buzzword, right? Unmet need. So seronegative myasthenia gravis is definitely one of those things that fits the criteria for unmet need. We really need to work on developing therapies that are available to these people. So the reason I put this is also to highlight the point about, well, why are the therapies that are available on market not approved for use in all myasthenia? And this is the reason, because the population that gets defined for enrollment, that gets enrolled in these studies, is the population that the FDA tends to approve these therapies for. So that's the reason why a lot of these treatments, even though they're market, and even though we may think they ought to work in all myasthenia, right? They're not approved. Now, the other color in there, and I hope everybody can see this, is the red. Now, the drugs that are in red are complement inhibitors. And again, going back to what Dr. Mupidi said, and then what I reiterated, complement activation does not have a role in non-ACHR myasthenia. So there is a distinction there, mechanistic distinction. So those drugs, we probably don't expect them to work in seronegative myasthenia or MuSK myasthenia or LRP4, okay? All right, so hopefully not everybody is asleep, and hopefully I've covered this all for you guys, okay? A few plugins, if you guys have any doubts. There's this one website out there that has great resources. You can identify provider lists from there by region. Again, going back to that point of don't be afraid to ask for a referral for a second opinion. It could be life-changing, okay? Clinicaltrials.gov is a federally run trial. Every trial that is occurring in the United States has to register with this and has to have a trial number. So you just go in this website, put in myasthenia gravis. You can just start with that. You can put in your location, and it'll give you a list of all the trials that are active, recruiting, coming up, concluded, some of the trials. So now the FDA also mandates that the trials put in their data or the top line results. So some of those will be there for the completed trials. So it's really a very useful website for tracking that. And again, circling back to the plugin, there is information on all the clinical trials occurring on the MGFA website as well. And where's Mike? Mike's been working like crazy trying to revamp and make it a better experience on the website. Another plugin, this is for the MuSK patients specifically. So the MGNet is a rare disease clinical network funded project, RDCRN. That's a federal fund, federal grant that is run by Dr. Kaminsky out of George Washington University. So they have this trial or study, I should say, looking at genetic factors in MuSK myasthenia. So it's very, very simple. If you have MuSK myasthenia and can confirm your antibody, then you can register for this study, and all they need is spit, saliva, literally. They have folks here at their desk near registration. So please stop by. Even if you don't have MuSK, you know somebody who has MuSK, take their information for them, and they can maybe help with that study. And that's it. I'm
Hi.
told I've run out of time for questions, so thanks, everyone.
Hi, Dr. Habib. We're going to take one from the online community. What happens if the clinical picture fits and patient has good response to meds, but the repetitive nerve study and single fiber EMG is negative or equivocal?
So this is where I would quote Chip Howard and say, it depends on which muscle you tested. So again, repetitive nerve stimulation testing has its limitations on where we can test it. So there are only a few specific places. We know for a fact that folks who get the repetitive nerve stimulation further out in the limbs, that has a lower yield than when you do it higher up. So that can be a factor. Technical factors like temperature, positioning, all of those things play a big role in repetitive nerve stimulation. So when somebody tells me that it was positive, I'm usually saying, well, show me the data, because I want to look at, like Dr. Lee's group pointed out, I want to look at the tracings. I want to look at the parameters that were studied during that. So negative or positive. So that's one part of it. The second part is people at different times in their myasthenia journey can have positive or negative. So if somebody is very well controlled and their rep stim is negative, well, yay, great. We have got them under good control. That's why the rep stim is negative. Same kind of technical issues, even more, the technical issues come about with single fiber EMG. Not all muscles will reflect that abnormality, and it depends on where they are in their treatment. So again, it's the whole picture that you have to look at, not just one factor. So if somebody has symptoms and exam findings that are consistent with myasthenia, had the kind of response on the time scale that I would expect for X, Y, or Z therapy, I don't particularly care that their rep stim or single fiber is negative.
Hey, I stutter, so bear with me. A sort of question comment. When I was first diagnosed with myasthenia gravis, I was seronegative. Okay, I'm seroequivocal now. I'm not positive, 3 points away. However, CellCept didn't do a lot for me. I'm on 100 grams of IVIG every 2 weeks, but I started Ultomiris in the latter part of December, 1st of January, and it's helping. I mean, I'm probably 50% back to my original baseline where I was normal before MG. Just a a comment.
So first of all, congratulations on getting a medication that's working for you. That's awesome. You will have to educate me of what antibody equivocal means. Not sure about that term. I'm assuming it means you're on the borderline as far as the testing is concerned.
So it looked like there was roughly a 30-point spread between negative and positive, and I fall in the middle. So I'm sort of in a gray area. It's like, well, you're technically seroequivocal. I'm not negative, not positive. I'm in a gray zone. It was very difficult to get the Ultomiris approved. I, as the patient, had to step in with the insurance company, and I was able to get in touch with the case manager and turn a appeal denial into getting the appeal reopened. And my physician was able to do a peer-to-peer. Wasn't easy, but he's pretty forceful, and he was able to get it approved, the Ultomiris.
So if anybody had any doubts about what advocacy looks like, that's what advocacy looks like. And I think your answer kind of helped me clarify that. I'm assuming, okay, I kind of have a sense of which antibodies you might be talking about. Blocking. Okay. Yeah. Yeah. So that also brings us to the point of, there are different flavors of the AChR antibody, and they're not all created equal. I'll stop there. Mike, please. Laura. Oh,
My question was regarding single fiber EMG. How specific is it for myasthenia gravis, and how common is it for it to be positive in like mitochondrial disorders and genetic disorders and things like that?
you have a particular interest in mitochondrial disorders, don't you?
Me?
Well, I thought there was a question earlier on from that same part of the room,
Oh.
I'm assuming. But so that's a great question. Single fiber EMG is highly sensitive, which means when there is an abnormality to be picked up, it will pick up that abnormality, but it is not very specific. What that means is it can be abnormal in conditions other than the condition you're looking for. Your arm's going to get tired. And so, yes, we always keep this in the back of our minds, as well as tell our trainees this, that just, you have to get, it's ALS, classic example, where it can be positive or abnormal. Right, several other muscle disorders, people who've had nerve injuries, it can be abnormal in those. So it's not specific to myasthenia. Again, that same point, that not just a test determines whether you have or don't have myasthenia. It's the full picture that you have to look at.
Thanks for giving me the opportunity to.
I'm going to stop you here. First, you have to tell us where you're from.
Oh, I'm from the Washington, D.C. area, but I'm a Nigerian American.
But West Indies is an archipelago. There are many islands there.
Interesting. I'm from Nigeria.
Oh, sorry. I thought you said West Indies. Sorry. Go ahead.
You all will agree with me that most of the MG patients here did not get it from birth, right? They're not congenital, right? So I'm thinking, is there a trigger factor that generates MG? Have we ever thought about that? What happens to someone to start to develop the symptoms of MG? Has that been studied?
I'm gonna be even more succinct than Dr. Mopidi was this morning. I don't know. I don't think we know what leads to or triggers MG. So in some other autoimmune neuromuscular disorders, there is the idea and concept of molecular mimicry. I'm just going to spend a second there. What that means is the body or the immune system sees something that's not part of the body and identifies it as foreign and starts attacking it as it is designed to do. But that has some similarity to some part of the body. And so as a corollary, that immune response then also attacks that part of the body. So in neuromuscular disorders, one type of Guillain-Barré syndrome, we know very well that their molecular mimicry plays a role. But we don't have that kind of a thing in myasthenia. Okay. We often, in the majority of instances, patients don't have an inciting event or a preceding event that triggered the onset of symptoms. They just wake up one day with a droopy eye, and that's the start. So we've not really identified clear triggers or why. So maybe that, here's a plug-in for that Musk study, that the genetic basis for that might help inform more about your, did I answer your question? Thank you. Yes, ma'am.
Well, after everything you've been talking about, I'm ready to go take on the next, what is it? The AAN conference, the American Academy of Neurology. We're all ready to go storm the castle. So I guess my question is regarding seronegative and the chances that there might be a misdiagnosis, right? Because it's horrible to be misdiagnosed with something you don't have because you're getting these treatments that you don't need. But where I guess the problem comes down to, we know we're sick, right? We know there's something wrong, right? And it's hard to get the physician to listen. And if that initial test comes out wrong, I guess the problem is, what I'm getting at is, how do patients, or what is the plan for more of a standardization in testing? I said it earlier with even with ACHR positive people, where a doctor starts at binding. If you're not positive on binding, you're done. You don't have it. And you say, well, I'm sick. I don't feel well. I have all these symptoms. Well, you don't have it. You might get a doctor to do an EMG, but that's not the, real one. But maybe eventually you'll find somebody who will diagnose you if you have one of the antibodies. But it's even worse when you have no antibody, you have all these horrible symptoms, and then you need to ask, okay, fine, if I don't have that, can we do genetic testing? So is there, because you guys that are here today presenting are the leaders in this, is there a plan to get more of a standardization out there to get this better understood? Because you don't want people misdiagnosed with MG if they don't have it. And I've seen that before too, just in support groups. A woman I met eventually ended up, she has a mitochondrial myopathy, and then later so did her child. But so how do we get to that point with doctors?
So I'm sure you guys have all heard. So I'm going to talk specifically about myasthenia first. You've heard myasthenia being referred to as the snowflake disease.
Right.
And by that very definition, it's very difficult to have a standardization across the board for all myasthenia, right? That is the inherent nature of the disease. It's not all the same. This is not an alien concept to us who see neuromuscular disorders. I'll give you a very short, quick example of ALS. We've all used to think that ALS was one disease because it manifested a certain way, but we've become more and more aware that it really has many different forms. It just ends up looking similar, right? As does myasthenia. So that's the challenge here. So it's very difficult to standardize something for a condition you don't fully understand and that you don't have all the information on. That's the challenge. Moving away from myasthenia, right? And really talking about each individual person. It's very important to have a partner in your care. What I mean by that is the physician or the clinician that you're seeing has to partner with you. And it's not simply saying, yes, you have myasthenia, and no, you don't have myasthenia. And I say that all the time, right? But that's a limitation of what I see, because I am in my capacity as a neuromuscular clinician, I know a lot about these kind of disorders. And so the conversation always is, you have a problem. We have to figure out where that problem is coming from. And yes, it's not myasthenia. I'm going to put it in a different way. I tell my patients that getting to a diagnosis for any patient is like making a puzzle. Sometimes the puzzle is a 10-piece puzzle, like for those 5-year-olds, beautifully colored. You have a picture to go off of. You put 2 pieces together, you know exactly what you're looking at. Other times, it's a puzzle in grayscale with 1,000 pieces, and there just aren't enough clues on how all those pieces fit together. And as those pieces begin to fall into place, then the picture emerges and you get to an answer, right? The second case that I talked about, it may not have been obvious 10 years ago, 15 years ago, when that patient started. No physician is doing this out of malice, right? We all got into this to help people. But sometimes it's a matter of time of just getting to that other diagnosis. But the important part here is, if you're not getting the answer of, then you have to branch out. You have to find other avenues, other providers in the same field. And again, that does not mean that your therapeutic relationship with the provider who's been caring for you should end. This should really be complementary, right?
Thank you, Dr. Habib. We appreciate your talk and all
Thank
the
you.
information that you gave us today. Everyone, we
I'm
have a,
happy to take questions
okay,
outside as well.
we have a break for half an hour. So our next session starts at 2:30. The next session starts at 2:30 and the one after at 3 o'clock. Then we'll have a break until later.
Check 1, 2. This is the lab test. Yep. Lab check 1, 2. Check 1, 2. Lab check. Lab mic check 1, 2. Check 1, 2. Hey, hey. Check 1, 2. Check 1, 2. 1, 2, 3, ABC. Check 1, 2. 1, 2, 1, 2. Hey, hey. Check 1, 2. 1, 2, 3, ABC. Check 1, 2. Check 1, 2. Check 1, 2. 1, 2, 1, 2. Hey, hey. Check 1, 2. Ooh. Check, 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 1, 2, 1, 2, 1, 2, hey, hey. Check, check, 1, 2. 1, 2, 1, 2, hey, hey. Check, 1, 2. 1, 2, 3, ABC. I got rid of some of the lows. They're just getting kind of. Check, check, 1, 2, 1, 2, hey, hey. And it looks good right there. Check, check, check. Okay. Check, check. Talking thoroughly through this lav microphone. Testing 1, 2, 1, 2, 1, 2. We're talking really good right now. Check, 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 1, 2, 1, 2. Hey, hey. Select. Check, 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 1, 2, 1, 2, 1, 2. Hey, hey. Check, 1, 2. 1, 2, 3, ABC. Testing 1, 2, 1, 2. Hey, hey. Check, 1, 2. Connecting it right. Nope. It did not go through. Connecting, connecting. Yep. Testing, testing. Wow.
This one? I think I'll be okay without that. Thank you, sir.
Hi, everyone. Hopefully people will trickle in as they hear we're starting. I think you all know I'm Dove 11, the National Senior Director for Patient Programming and Education. I would like to introduce Lisa Bulot, who is a Patient Education Manager at Alexion. She provides support and education to patients and their caregivers throughout the Gulf Coast region. Please welcome Lisa.
Hello, everyone. I'm very loud, so I'm hoping I'm not too loud for you. Okay. My name is Lisa Bulot, but Dova pronounced my name so much better. We may change it. Thank you all for coming. I would like to start off, and may I ask all of our caregivers to stand up, please. Yes, we see you, we hear you, we applaud what you do every day. Sometimes you can feel like you get lost in the shuffle, but we know you are the rock stars. So let's get started. This is an educational program for those of you who are caring for loved ones with GMG. So today in this program, we're going to talk about self-care as being a partner. So it's so important to you. If I step back, tell me to step forward, okay? It's so important that you take care of yourself so that you are able to take care of others. So just a few housekeeping rules, and I know you've probably been through these today already. So this is an educational event. For questions about your GMG management, we're going to refer you to your physicians. They know you better than anybody else, so we're going to let you ask them your questions. So we're going to start with a quote from one of our GMG care partners. And she says, "The main support I provide at this point is to be there with him during medical appointments. I stay in touch with his healthcare team and help him manage. But even though we haven't had to adapt much yet, GMG progression varies and the future is always on my mind." As you know, GMG is referred to as the snowflake disease. Each snowflake is very unique and there's only one like it. So is GMG. The symptoms are very different from patient to patient, from day to day, and from hour to hour. So we never want you to compare your loved one's symptoms with someone else because they are their own unique person. So we're going to talk about a little bit of strength and support, how to leverage your role with the healthcare team. Because as you know, it's not just your loved one or the patient with GMG. There's physicians and nurses. There could be physical therapists involved in the healthcare team. You could have home health. There's infusion center nurses. So your healthcare team is wide and varied, and you are part of that team. You play an integral part. Because when you go to those physician appointments with your loved one, you are the extra set of ears that is needed. Because we know when you get bad news, everybody stops listening. It is an innate, it's in all of us. We just don't want to hear anymore when we hear something bad. So always bring your care partner with you to the doctor's appointments. You have two sets of ears. When your loved one with GMG forgets to ask a question, you're there to help ask that question. You may have your own questions. You see things that the person living with GMG doesn't see. You see those little nuances, those little changes in symptoms. So you're able to bring those to the forefront and be part of that team. So Alexion has developed online educational materials to help you with this. There's an MG Activities of Daily Living, which is sort of a symptom tracker. So when your care partner says, I am not having any trouble eating, you can say, well, you used to like steak. Then we have started having to cut it up in little bitty pieces so you could eat it. But now you don't eat steak anymore because it's too difficult for you to chew. So we've switched to soups and mashed potatoes. So those are the little things that you pick up on where your person living with MG is like, no, I'm good. I still have breakfast, lunch, and dinner. But their diet has changed tremendously. Or maybe because they used to brush their teeth with a mechanical toothbrush, but maybe they've moved to an electric toothbrush. They're still brushing their teeth. So when the doctor says, you having any problems with all your daily living activities? They say no. You're like, hold on. You're not the nagger. You're just here to give the truth a little bit. There's also a doctor discussion guide. So that just kind of helps you take charge of the conversation. When you walk into the doctor's office, I have found with my patients and with loved ones that if you walk in prepared, maybe you have this MG-ADL and you have this doctor discussion guide. You have questions that are ready to go for the doctor. Those doctors appreciate that you're prepared. They'll actually give you a little extra time in those appointments. So they're not trying to run from one to the other like, oh, they're ready for me. Let me sit and talk with them for a little bit. So what is the definition of self-care? It's the practice of taking an active role in protecting one's own well-being and happiness, in particular during periods of stress. So not all stress is bad. Sometimes stress gives you that extra little burst of energy to get those tasks done that you need to do. But when stress stays high and constant, it can cause problems. So what are some things that you can do to help with that? You want to nourish your body with healthy foods, maybe healthy portions. Sometimes we love food and it tastes real good, but when we're eating this much of it, it's not so healthy for you. You want to cultivate a care plan for yourself. So you want to find an exercise program. You want to get your heart rate up. Any way you can get your heart rate up. Might be singing, dancing, laughing, walking, whatever you like to do that makes you happy and get your heart rate up. That's what you want to do. You want to replenish your mind and body with rest. Sleep is very important because we know if you're not sleeping, that adds to your stress too. So there are lots of barriers to self-care because we can come up with all kinds of, some people want to say excuses, but they're really more barriers. They're not excuses. This is what you really feel. If you're feeling guilt about taking time for yourself, if you looked at another caregiver giving care to say maybe your father, you wouldn't think of them as being guilty. You would give them grace. So give yourself some grace. Try to come to the root of what the stress is. So a lot of people like to journal. Journal's a good way to express your feelings. You can express your feelings. You can kind of decide, well, maybe it's a certain time of day. Maybe it's 2 o'clock in the afternoon. Maybe it's time for a nap, but you don't need the nap and you're getting irritated with people. So sometimes it's just 10 minutes that you need just to take time to yourself. Do you feel selfish if you take some time for yourself? Yeah, a little bit. Some people are saying no, and I applaud you because you've dealt with that feeling. So be kind to yourself. Do you feel weak when you ask for help or don't take time for yourself? That's not weakness. You can't carry everything on your shoulders. You can't do everything all the time by yourself. So we want you to reframe that That's strength. Strength because you can do so much. There's just some things that you can't do and you need help. Are you unaware that stress is affecting you? And most of the time, people are unaware of how it affects them. So are you starting to snap? Are you getting irritated? So what I like to tell everybody to do is try to do a body scan. You can set an alarm for 1 or 2 times a day or a couple times a week. Start with the top of your head. You start there and you start scanning your body. And all of a sudden you realize, are my eyes kind of tight? Are my teeth clenched? Are my jaws tight? Am I holding my hand in fists because I'm so anxious I don't know what to do? When you start doing that, you can feel the tension. And when you feel that tension, go muscle by muscle and try to relax. Good time to do this is right before you go to bed also, because you can start there and it really will relax everything. You'll get a better night's sleep. Time. Time is the biggest barrier because you have lots of things, lots of appointments to take your loved one to, and you find that time is hard to take a chunk out of. You don't need a big chunk of time. Sometimes it's a few minutes to take a few deep breaths and exhale, just to take time for yourself and just stop. Take a few deep breaths. Sometimes it's going outside and just standing in the sunshine and let the sunshine hit your face. It does wonders for you. So just remember, sometimes you can take little pieces of time and not a big chunk of time for yourself. So let's talk about communication between you and your partner. This is the key to both of your self-care needs, because the person living with GMG has self-care needs, and so do you. Some people love to do everything together. So they're going to problem solve together. I have self-care needs, you have self-care needs. Maybe we can meet in the middle and we can find what works best for us together and take care of ourselves. Some people need me time. Just a little bit of alone time, not long. So that's a great discussion to have between you and your care partner. So we're going to just stop. And I just want everybody to think for a second. Have you had this conversation with your loved ones about what your self-care needs are? You don't have to tell me truth or false. Just think about it. And if the answer is no, this might be a good time to have that discussion. It's a good time to start that discussion because this is very important for both of you. So we want you to find ways to assess your stress. So what are you feeling? I know sometimes it's hard to decide and sometimes you get confused. Am I anxious? Am I feeling things? Are these anxious feelings getting worse? Because it's not uncommon to be stressed and have a stressful event and then it goes away. Or you feel anxious and then it goes away. I was a little anxious before I started. It's sort of gone away. So, get in tune with yourself and really ask yourself these things. Okay, is it a certain time of day? Keep a journal. Is it a certain time of day? Is it a certain event? Is it infusion day where I know I've got to be at the infusion center with my partner? I've got to be there at a certain time. I have to say this block of time. If that's what's causing you anxious feelings. So just kind of scan and review what is causing these issues. Are you having sleep problems? So sleep is a big issue when you are stressed. Some people will sleep more. So you can be at both ends of the spectrum. Some people are going to wake up, maybe they have difficulty going to sleep, or they wake up in the middle of the night and their little mind starts racing. This is a good time for a body scan because it kind of gets you out of that pattern of worry about what the things you have to do, and it's about yourself and calming yourself down. So are you avoiding people or activities that you usually love to do? Because when you get stressed, you kind of want to keep it all in. You don't want to tell anybody. So I'm not going to go play bunco on Thursday night with my friends. You only do it once a month. Take the time for yourself. If you're avoiding people, just pick up on those cues and ask yourself. So what are some ways that you can identify your stressors and then create a care plan? So we're going to go through a few little scenarios of things that are happening. And I know every family is a little different. We're going to talk about Aunt Karen for a second. Aunt Karen is that aunt, and she is so concerned, and we love her to pieces, but she calls all the time. and she wants to know the updates. And this is starting to stress you out because you know Aunt Karen's calling, but I've got 10 things to do before Aunt Karen calls, and I don't want to stop and talk to Aunt Karen. What can you do? Find a way to handle that stress. Maybe you could give it off to a family member and let them update everybody. Some people have group text. You can put every family member on that group text, give an update once a week, once a month. There's Facebook. I see family members putting an update on Facebook. That updates everybody that you've ever known in your entire life. You don't have to update them. But there are also websites that you can use like Caring Bridge to give an update. So find ways to lessen the stress on yourself. What if meal planning is your stress? You've got all these things and now you have to cook. You have all these things you have to do. Well, there's grocery delivery now. It is wonderful. There are meal plan programs. They will drop a whole meal at your doorstep. They'll drop 3 or 4 if you want them for the week. My daughter-in-law does this. She goes, it's the best thing. She can't cook, but she can with the meal plan. So find ways that are going to alleviate some of the stress for you. You know, if finances are an issue, sit down with a financial planner, a CPA to help you figure out your budget. If you're a stress eater and you've started to put some weight on because of stress, well, maybe you find a buddy and you start your healthy plan. I don't like to call them diets. It's healthy. Eat healthier portions. So there's lots of different things you can do. So find what's causing your stress so that you can have some self-care time and take care of yourself. So beyond the big 3, nutrition, exercise, and sleep, you need to stay connected to family and friends because you don't want to isolate yourself. So there's video calls now, so you can actually feel like you're visiting with people, even if they're far away. This is one of the best things I think about these iPhones is now you can sit and talk with people. You always want to take a moment for you and you want to do something that makes you smile every day. If you like to dance, when that favorite song comes on, dance like nobody can see you dancing. If you like to sing. I can't sing, but I like to sing. I just sing in the shower so nobody can hear me. Find things that make you smile, that make you belly laugh, and it really will change your whole perspective on your day. So this is another quote from another one of our GMG care partners, and it says, as well as learning to take care of your loved one, you really need to learn to take care of yourself, to keep yourself in good shape physically and mentally. That can take many different forms. I find walking a lot, getting exercise is helpful for me. I also do a lot of spiritual things to build that side of myself. So your mental health is extremely important. Your physical health is extremely important. You just have to find what works for you because it's not a cookie cutter. What your person sitting next to you likes to do is not what you like to do. If you don't like to do it, you're not going to do it. So find something that you love to do. Build your toolbox. Just like you have a toolbox at home that's full of tools, my neighbor has a completely different set of tools. So it's going to be what works for you that you put in your coping toolbox. So is it that you like to call a friend or do you like to write letters? Writing letters is almost a lost art, but some people find it very cathartic and helpful. You want to share your feelings with the people you trust. Don't keep things built up inside. They kind of tend to fester when you keep feelings built up inside. And it's always nice to share with somebody. Pamper yourself every now and then. It's important to take care of yourself, and it's okay to pamper yourself. We talked about laughing. Laughing, they always say laughter is the best medicine. So find that friend that always makes you laugh. Everybody has one. So call that person. You're going to laugh when you talk to them. You can't do everything all the time. And maybe you were that go-to person that you never said no to anybody, that you helped everybody with anything that ever needed to be done. Bringing kids to everywhere, to cooking, to making brownies. Well, maybe you have to say no to the brownies. It's okay to say no to making things. Get some of those things off your plate so that you can take time for yourself. Remember, things don't have to be perfect. They just have to be done sometimes. So you don't have to be perfect. Some people have mantras. My mantra is, this too shall pass. So when I get stressed or I don't have time for myself, and I just say to myself, this too shall pass, it kind of gives you a second just to think and to move on. So find your own mantra and listen to it every day. Say it to yourself repeatedly. Find something that makes you happy. Are you an arts and crafts person? Maybe get back to crocheting, needlepoint. If you like to exercise, find that exercise that you like to do, or walk. Just be outside with nature sometimes. Some people like to take pictures, so you can make a collage and you could put it out for everybody to see that comes on. You smiling with your loved one. It's going to put a smile on their face. It'll put a smile on your face. So why not do something that's going to make you smile? So what's your favorite coping strategy? There's all kinds. We have some listed here. Taking a deep breath. You can pray or meditate. You write in a journal. Phone a friend. You can vent on social media. Some people like to let everything out on social media. Or you can exercise. It's whatever works for you that gives you time to yourself, that helps you refill your cup. You cannot pour from an empty cup. So make sure your cup is full before you start pouring for somebody else. We want you to make use of your network. You have lots of family and friends. Maybe you've got a few family and friends. You have neighbors. You have lots of people, probably when the diagnosis first came, that reached out. If you shared with people and said, I'd really like to help, what can I do? And at that point, you were just trying to get a grapple on what GMG was, what is life going to look like, what do I need to do? So you didn't have time to even allow anybody else to help. Those people still want to help you. So take advantage of them, but you really want to be specific. So when you call somebody, you don't say, hey, can you help with Bob on Tuesday? That's a very large ask of someone. Maybe if you said, hey, Bob isn't going to infusion at 10 o'clock on Tuesday, and I'd like to go run some errands. Would there be any way that you could pick him up between 11 and 11:30, or wait with him while I go run some errands, and I'll meet you at the house as soon as you're finished? How many people are going to tell you no if you ask very specifically? Because they know you need help. And when you reach out, they're willing to help. So make sure you do. There's lots of social media pages, neighborhood pages, county, state, federal programs that are out there that can be part of your network. You have MGFA. How lucky are you all? You have this that they give to you. They provide all sorts of resources for you, but there are other things out there that provide resources too. So your phone is an extension. I mean, it's the best little supercomputer that you could ever have, and it's right there in your hand anytime you want it. You can use it for social media. You can use it for journaling. That little one, those notes sections, great for journaling, writing down your ideas. So there's lots of GMG websites. You can do video calls and use any kind of mobile apps that you need. So what technology do you find helpful? So here's just a list of them. You can email your healthcare team now. I think that's fabulous because they actually answer you. You leave a message, maybe you get a call back, maybe you don't. Emails are very effective in an office. There's telehealth. So telehealth has helped a lot, and some physicians have kept some telehealth appointments. So that's nice if you can kind of flip-flop back and forth between an in-person visit and a telehealth. It just saves a lot of time. Smartphone reminders, there's GMG websites, there's journals, video calls, and there's even apps for relaxation and meditation. So there's lots of GMG specific resources. Of course, you have your MGFA, and these are some other ones. There's general caregiving resources. So Family Caregiver Alliance is a good one. AARP has resources for caregivers too. And then Caring Bridge, which we talked about for a few seconds, it can update family members on what's going on with the patient with the MG. Then there's morethanmg.com. So make sure you visit that website. It's a good resource. There's also training for informal caregivers. So, one day you were just doing what you needed to do, and the next day you were a caregiver. there's no really manual on how to be the best caregiver, but there's some informal training for caregivers now. So please use them. There's federal, state, and county agencies that provide. There's Caring for You, Caring for Me. There's powerful tools for caregivers, and there's caregiver.org. So make sure you use these if you haven't been to them yet. So I know that we have covered lots of information. So I've left a little bit of time for some questions. Now we're going to ask that if you've got any specific questions for your symptoms, your specific GMG, we're going to ask you to refer those to your doctor. So I can't give medical advice, but if you have any questions, just raise your hand and Dova has the microphone if you have questions. Or if I've done a really, really good job, you won't have any questions. No, anybody? Okay. If you have questions, I am around all day today and tomorrow. I would be glad. I would love to talk with all of you. And I think I have met a lot of you. So I want to thank you for having me. My name is Lisa Bulot. I cover the Gulf Coast. We have PIMs all over the country that can help you. So if you need anything, and Alexion did sponsor this program, this educational program, so we thank them for that. Thank you.
Thank you, Lisa.
Good afternoon. Next up, we have Judith Thompson. Judith is an experienced pharmacist who is currently working as the Rare Disease Population Health Strategy Lead at UCB. Please join me in welcoming Judith Thompson.
Well, thank you. Thank you for the warm welcome. This is my clicker. Perfect. So I know I'm the last presentation before break, so I hope I make it worth your while. Welcome to the MG journey, More Than Medicine. Oh, can't see my slides. Perfect. I got to admit to you all, if I can be honest for just a second, I was a little nervous when I was trying to decide what to present to you today, because you are the audience that when I went to school, I pledged to help, pledged to serve, pledged to support. I talked to physicians and PhD researchers and people in academia and all kinds of healthcare providers all the time. But this audience, I wanted to make sure I brought you something meaningful, something informative, because you're my daily motivation. When things at work get hard and I'm trying to fight the battles, get programs started and get research completed, I think about the journey that you're on. And that makes me want to do more, push through, and work harder. So I hope this is meaningful information for you, especially because it's the last presentation before break. So I'll take you on a little journey of my research, as well as some information that we share a lot of the times with providers, but I'm not sure that information actually gets shared down to patients and their families. Kind of already done a little welcome today. I'll introduce myself. I'll tell you a little bit more about me. Tell you about the social determinants of health, what they are, what they mean, and how they impact the MG journey. We'll talk a little bit about health inequities in rare disease, and then I'll finish with UCB's commitment to rare disease and some research examples. So there's my face in much younger years. I'm a pharmacist by training. I've worked in the community pharmacy for about a decade or more. That's your local drugstore, Walgreens, CVS, et cetera. And I'll tell you, it helped me learn a lot, because what I didn't know was growing up, my family went through our own personal journey with what was then considered rare disease. So late 80s, early 90s. My dad was misdiagnosed and then eventually diagnosed with multiple sclerosis. I did not know that things beyond the healthcare system actually impact how well you do, how quickly you're diagnosed, the treatment that you get. You couldn't tell that 8 or 9-year-old little girl that where we lived made a difference on what type of healthcare we received. As I began to work in the community pharmacy and start to help other people living with chronic illnesses or sometimes just a cold or flu, helping them to understand how transportation or geography or the amount of money in their pocket could impact the medication they could afford and the doctors they could have access to. I helped them to get over some of those barriers. And this work is so meaningful to me because in rare disease, I don't have to tell you, it's even more intense because you're battling so many additional journeys. So we'll start with the social determinants of health. By show of hands or head nods, how many people have heard of this term before? Very little, okay. So then this will be informative, glad you stayed. So social determinants of health. The CDC defines it as the conditions of places where people live, learn, work, and play that affect your health outcomes as well as your quality of life. The one takeaway that I think is meaningful for this audience, and again, we talk to providers, health systems, executives within healthcare systems about the social determinants of health all the time. Apparently that information does not get passed along. So that's why I wanted to bring it to this audience to make sure that you all understand how some of these barriers may be impacting your journey. Almost 80% of the factors that contribute to how well you do with your journey are outside of the healthcare system. And they're called the social determinants of health. So the World Health Organization defines social determinants of health as non-medical factors that influence health outcomes. They can be more important than healthcare or lifestyle choices and health outcomes. So that's that 80-20. 80% is social determinants of health, 20% is your actual healthcare delivery, the system, the medications. Social determinants can be grouped in about 5 categories. So this is the healthy people 2030s, 5 categories. Economic stability, so we kind of talked about that a little bit. How much money you have in your pocket, how much your employability, if you're able to retain employment due to your illness. Socioeconomic status, right? So the balance between your bills versus what you're bringing in, how much security that provides you, that's your economic stability. We talk about education access and education quality. So what's the underpinning there is health literacy, right? So sometimes health literacy, general literacy kind of go hand in hand, and the ability to make healthcare decisions based on the level of understanding of the information that your doctor or nurses, or even sometimes the internet, how much information we consume from the internet, are we able to digest it and actually utilize that information to help us make healthcare decisions, to inform our healthcare behaviors? But general education access and quality also plays a huge role, just because it's a lot of the times dependent upon the neighborhoods we live in. So you'll see that second to last bullet, neighborhood and built environment. Education and neighborhood kind of go hand in hand, right? Has a lot to do with taxes and redlining, but I won't get into all of that. But neighborhood and built environment also deals with how safe it is sometimes to go outside and exercise. Do you feel comfortable walking outside your front door, and how much that aids in your health and wellness? Neighborhood and built environment and healthcare access and quality also go hand in hand, because if you don't have access to the providers or the specialists that you need, that can play a role in how quickly you're diagnosed. If you're diagnosed correctly, the specialists that you have access to, and if they know how to necessarily treat your condition. Social and community context. This one came out a lot during COVID because everyone was isolated. And what we saw was that that social connectivity really played a part, especially for our aging populations, really played a part in how well people were living and able to cope with being isolated and not able to really interact with other, like human to human contact. But it also plays a great deal in the amount of support you feel, and the amount of support and social connectedness that you have really plays a huge part in your health outcomes. One that's not listed on here, it's kind of emerging as the sixth social determinant of health, is technology, technological access and technological literacy. So telehealth is a huge service that I hear a lot of people boast about in terms of being able to reach those that may have neighborhood or geographic barriers to healthcare. But what if you live in an area that does not have the infrastructure to support your Wi-Fi? What if you just can't, you don't have a phone that actually supports telehealth services? What if you just don't really feel comfortable getting on the computer and maneuvering around all that stuff online? If that's a service that's being provided to mitigate some of the challenges in your healthcare journey and you don't have the technological literacy or infrastructure to support that service or for that service to be supportive to you, then it becomes more of a factor that adds to the disparities of care. So the differences that we see in those that can and cannot have meaningful access to a healthcare provider. Consider, if you will, out of the couple of social determinants that I've named, how some of these may have impacted your journey, your diagnostic odyssey, your treatment journey, how economic stability or education or neighborhood, geography, technology, social connectedness, support from other people with or without MG, how those may have impacted your journey. Because what we have learned is that social determinants of health play a major role on health inequities. And we'll get to health inequities shortly. Actually, we'll get to it right now. So the main takeaway for this slide is the difference between equality and equity. A lot of people use them interchangeably, but they're actually different. The picture on the right side does a good job of showing us equality is everyone getting the same accommodation, no matter what. Everyone gets a brown crate. It doesn't help everyone though, does it? Equity means that everyone gets the accommodation that they need in order for them to have the same opportunities. In this case, have the same opportunities to see the baseball game, soccer game, sorry. That's the difference between equality and equity. And if social determinants of health are an integral part or playing a part in how inequities are actually playing out in chronic conditions, we have some definitions here that will help us to, apply the social determinants of health to health inequities. So if we look at the first definition, it's the unfair and avoidable differences in health status. This is lack of equitable care may lead to health disparities. These are preventable differences, meaning everyone could have gotten the accommodations they needed on the right-hand side. That's why it's preventable. And because they're preventable, they're leading to health disparities in terms of burden of disease or injury or violence and the opportunity to achieve optimal health, right? And it happens in a lot of different dimensions of diversity. There's not just one social determinant of health or one health inequity that leads to one health disparity. This is for a variety of what I like to call dimensions of diversity or factors. So it could be, again, based on socially disadvantaged, economic status. It could be race, ethnicity, and culture. It could be based on geography, if we think about rural versus urban. Again, I'll ask you to consider how health inequities may have intensified your journey, right? It could contribute to barriers in adequate testing, depending on the provider you've been able to have access to. Geographic barriers, if we begin again to think about distance to a provider or distance to a specialist, or even distance to a hospital in case of a crisis. Racial and ethnic disparities, a lot of the times, plays into how someone perceives life or how people perceive them. So those perceptions go both ways from the provider as well as certain cultures and how they go about healthcare behaviors, how they look at their relationship between patient and provider. Is there a hierarchy there? Do I feel empowered enough to say what I feel, to say what I think, to challenge the decisions that the doctors made? We've done research in the past that actually show that there are some racial, ethnic, and cultural barriers to patient-provider communication. And that's a two-way communication. So it's not just perception one way. We talked a little bit about health and digital literacy. So again, thinking about how those inequities can intensify the challenges of the GMG diagnostic and treatment journey. And I think one that will hit really big with this audience from stories that I've heard in the past is bias and gaslighting. When you're presenting with symptoms that people are telling you, maybe that's something else. Maybe it's more of a mental health disorder. I can't find that in the tests. Maybe it's not there. And how that contributes to misdiagnoses, delayed diagnoses, they're also contributing to health inequities and disparities that people may be experiencing along their journey. So these different dimensions of diversity make every journey unique. We talk about MG as a snowflake disease, but think about MG in terms of social determinants of health and health disparities and how that just intensifies. Can I say intensifies the snowflake? I don't think that makes sense. So we'll take a little bit of a look at some research that I did where we looked at claims database. And so just to give you a background on claims, every time you go to the doctor, the hospital, the pharmacy, that interaction is recorded as a transaction in the background in your health records. And so we can pull those claims or those transactions for different types of studies or analyses. This particular study, we pulled medical and pharmacy claims for people living with MG in 16 states in the US. There were almost 9,000 of those individual patients that we were able to pull claims for and verified that they actually had MG. And over 3,000, so 35% showed evidence of suboptimal treatment. Here we have suboptimal treatment defined as not initiating acetylcholinesterase inhibitor therapy, greater than 10 milligrams a day of corticosteroids for 6 months, greater than 300 milligrams a day of azathioprine for 24 months, or greater than 3,000 milligrams a day of mycophenolate for 12 months. That was considered suboptimal treatment for the purposes of this study. So what we found was that those with suboptimal treatment were more likely male, had fewer other health conditions, so fewer comorbidities, and they were likely started on treatment within 30 days of diagnosis. So started on treatment quickly after diagnosis, but by the definitions for this study, started on suboptimal treatment quickly. Even more interestingly, what we found was that those living within communities of high-risk food insecurity, meaning they had to make some choices when it came to getting food or providing food for their families, or the food that was available within their communities was not necessarily the healthiest foods. Maybe they lived in food deserts. There weren't grocery stores with good food options nearby. Those would be considered high-risk food insecurity communities. They're also more likely, those receiving suboptimal treatment, to live in communities with high-risk housing insecurity, meaning there weren't enough residencies to accommodate the population in that area, or houses or apartments were overcrowded with the number of people living there. Those communities or people living in those communities in our data set were at a greater risk of receiving suboptimal treatment compared to those living in low-risk communities. What this means is that providers may need to identify some of the social determinants of health for people that they're treating, identifying if they're treating people that are living in at-risk communities. And we looked at a lot of different social determinants of health, but these two stood out. So this is, I said 16 states, but all of this data was kind of aggregated, or the average of all those 16 states kind of rolled up into a larger analysis. If we looked at individual communities, zip code by zip code, we may find even more differences and more relevance as related to the social determinants of health that we listed earlier. If you think about your own communities and some of the other social determinants of health that we talked about earlier in terms of economic stability, healthcare access, transportation, geographical barriers, et cetera, the more localized you get to see a little bit more association or relationship between these different social determinants and then the unmet medical needs, such as suboptimal treatment. But the takeaways, providers may need to identify if they're treating patients from at-risk communities to determine if they need additional support. There are resources available, but if the provider does not know that they are treating someone that may be in need of support, they may or may not know how to connect them with the resources that are already available. Additional research is focusing on the association of social determinants of health and other unmet needs. So we're looking at delayed diagnosis, misdiagnosis, delayed treatment, and how much it pertains to exposure to some of these risks factors as it relates to social determinants of health. If you think that some of these social determinants may be contributing to your journey, consider ways to talk to your provider about them. Like I said at the beginning of the presentation, providers are aware. They're aware of the social determinants of health. We talk to them at length. They get information from the CDC and from the World Health Organization. A lot of the times that information is just not passed along. And that's not saying that they get this information as it pertains specifically to MG, but for people living with chronic conditions, for people living with more prevalent conditions, this information is proven and given to them often around the association between social determinants and health outcomes. So consider ways to inform your provider if you feel comfortable and empowered enough to be able to do so. Say, hey, you know, I kind of only use my phone, so I don't know if I have access to a laptop or if I have access to a computer. If you're asking me to view things on a web page, I don't feel comfortable doing it on my phone. So then maybe they can get you some printable information. Or if they're considering other, methods of care pathway or treatment pathway that you think maybe your social determinants that are prevalent in your life are going to prevent you from carrying out that care plan, I would ask you to feel empowered to speak up about it because they are aware, but they just may not know the level of resources that you need. If we finish off with UCB's mission in rare disease, I won't read all of this to you because it's a lot, but the takeaway here is that our heritage and our progression of science includes more than just treatment, right? We're doing research not only in the social determinants of health, we're also looking at health equity locally in the US, we're looking at it globally, but we're looking at ways that we can create programs and interventions, not just medications, to support people living with MG. And that's all I have. Any questions? Oh, I thought there were questions. No questions? Y'all ready for the break? Me too. I understand.
Thank you very much.
Thank you.